Good evening, everybody, and welcome to the present webinar on algorithmic approach in septic and hemorrhagic shock states. I will act as your host. My name is Cesare Gregoretti. I'm coming from the University of Palermo. It is my pleasure to introduce our guest speaker, Professor Einav Sharon from the Hebrew University in Jerusalem, Israel, and Professor Daniel De Backer. This is coming from Zurich Hospital here in Brussels. We will have also some additional support from Dr. Andrea Corteggiani, who is also coming from the University of Palermo, and he will act as a scientific supporter, and he will collect your feedback and question. So do not forget to click the orange button to be interactive with us. I just want to tell you that our webinar is absolutely dedicated for be accredited for one CME, and so do not forget absolutely to apply to this CME at the end of our session in order to get your credits. We have also declared, our faculty declared the conflict of interest. They can also find on our website. I do not waste our time, so it's my pleasure to introduce Daniel.
So thank you, Cesare. I will, in a few seconds, begin this webinar by discussing the algorithmic approach in septic shock states. And I will begin by the physiopathology of septic shock. So very importantly, we need to understand the new definitions. And sepsis is a life-threatening organ dysfunction caused by dysregulated host response to an infection. And septic shock is a subset of sepsis in which the profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. Sepsis is due to a generalized endothelial dysfunction. Basically, when white blood cells, neutrophils, and monocytes encounter the bacteria, there is some reaction of these white blood cells, and these will, on one hand, stimulate the inflammatory process, but also the coagulation cascade on one hand, but also stimulate the endothelial cells, so that we will have some local vasodilation that will occur. When it will be dysregulated, this will lead to some more profound vasodilation, leading to a decrease in blood pressure. There is also some increase in the permeability due to the loss of barrier function, which is also very important. Altogether, these alterations may lead to tissue hypoperfusion and impaired tissue oxygenation, and ultimately in organ dysfunction. So septic shock is characterized by several aspects: systemic hemorrhagic alterations, regional perfusion redistribution, microcirculatory alterations, and metabolic alterations. Regarding these aspects, most of these alterations are related to the generalized endothelial dysfunction. Importantly, it is interesting to realize that this impairment in or alteration in endothelial function is really very important for the first step to control infection, because indeed we need this local increase in permeability to have the white blood cells coming into the tissues. Also, activation of the coagulation inflammation is also very important to combat the infection. This is the adaptive phase. But when this becomes to be maladaptive, then we have a generalized increase in permeability. The coagulation inflammatory aspects are really too elevated. And this ends up by impairment in microvascular blood flow, in regional perfusion, and generalized decrease in vascular tone, leading to this generalized hypotension. When we encounter our patients, it is usually because they change from this adaptive local reaction to a generalized maladaptive response. So for the systemic hemodynamic alterations, what do we have? On one hand, we have the vasoplegia, the decrease in vascular tone leading to hypotension. We also have hypovolemia due to two factors. The first one is the relative venous dilation. The second one is the absolute losses through the increase in permeability. Ultimately, we also have myocardial depression that can also lead to a low cardiac output in some cases. Regional perfusion alterations is also very important. We have an impairment in splanchnic perfusion. We have an impaired gut mucosal perfusion. We have also an impaired renal, but also intrarenal perfusion alterations. And this is leading to a decrease in glomerular filtration rate due to a decrease in the efferent arterial vascular tone. We have also impaired cerebral autoregulation. Microcirculatory alterations are also very important. We have a decrease in vascular density, a decrease in proportion of perfused capillaries, and heterogeneity between areas closed by a few microns. So I would like to show you a video of a patient with septic shock. And what we see is on the right upper corner, we have a relatively well-preserved microcirculation. However, on the left lower part, we can see that you have really red blood cells that are totally stuck and not contributing at all to oxygen exchanges in these conditions. So basically, you understand what is distributive shock, but you also understand that even though cardiac output may be preserved, you have some areas that are totally not receiving oxygen and thus hypoxic. So we have also, on top of this, some metabolic alterations. Oxygen conformance is very important, and I will explain you in a couple of seconds what it is, and also cytochrome decoupling. Oxygen conformance is very important. Why is it important? Because it helps these cells that encounter a decrease in oxygen supply and hence a mismatch between ATP supply and demand to survive. Why? Because if nothing occurs, there will be alterations in membrane, and this will do membrane rupture and cellular death. Because of the regulated hypometabolism, the cells are able to divert all the energy to really preserve the essential mechanism of keeping the membrane intact. Of course, it will be at the expense of other mechanisms, like for the kidney, the excretion in the tubules, for the liver, the secretion of bilirubin, or in the heart, the myocardial contractility. So the dysfunction of the organ is a price to pay sometimes for the organ to survive. So these alterations can often be limited by optimal resuscitation, which can indeed lead to restoration of tissue perfusion in these conditions. So the septic shock management will be essential in several steps. First, the patient identification, which is really very important. Second, the adequate and early antibiotics, but also the source control in this condition. Third, the early adequate hemodynamic resuscitation. And finally, supporting the failing organs while still minimizing the complication related to our support. And so organ dysfunction can often be limited by optimal resuscitation. And we will do all our best to try to provide this optimal resuscitation. I will illustrate this in a case-based discussion in a few seconds. This was a case of a 68-year-old male who had been operated for colon cancer a few days ago. Then he develops abdominal pain, but also fever, hypotension, tachycardia, tachypnea. We perform CT scan, you can see on the image, we have a pneumoperitoneum and collections. Then the first question, does this patient have sepsis? Well, if you look at the definitions, it's not obvious. Is this really a dysregulated host response, or is it regulated? Well, for this we can look at some clinical indicators or clinical criteria for sepsis. And the cue so far is really there. We have three simple signs: respiratory rate, ultramentation, and a low systolic blood pressure. And when we have an infection, and in addition, two of these cues so far points, we can say that indeed there is a very high likelihood that our patient has some sepsis. So in our case, we had indeed sepsis because infection is clearly identified, and also we have inappropriate host response suspected by clinical signs, hypotension, and tachypnea. So the next question is, does this patient have septic shock? And then it begins to be a little more tricky. Why? Because the sepsis 3 definition says that indeed it is a more severe subset. And this is clinically defined as hypotension, requiring vasopressors, and an increased lactate level above 2. So this is a little bit stringent definition, and we have a more broader definition in which indeed we have septic shock, which is just defined as a life-threatening generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. And then the indices of the impaired tissue perfusion, the clinical symptoms, is indeed more clinical, mottled skin, capillary fill time, and other things like this. So, does this patient have septic shock? Well, we do not have yet enough information, because indeed we have hypotension, but we do not have the use of vasopressors. But what about tissue perfusion in this patient? What about lactate? Well, I will give you this information in the next slide. Because indeed here, we can see that the patient was indeed hypotensive. He had some tachycardia, but if you look at the skin perfusion, skin is mottled. The patient is also unbunted, so some signs of organ dysfunction. And on top of this, the lactate is at 4.3. So indeed, this patient is in shock based on these clinical criteria. So I'd like to ask you a question. What do you do regarding the source control in this patient? Do you perform blood cultures, wait to surgery to give antibiotics? Or you give broad-spectrum antibiotics right away? Or do you perform blood cultures, give antibiotics as soon as possible before sending the patient to the operating room?
Thank you very much, Daniel. Please click the orange button to submit your answer. In the while we are waiting for the answer, Daniel, beyond the quick SOFA, which tool would you use to have a quick recognition of septic shock? I mean, what would you advise to measure?
Those are indeed several signs we can use beyond the QSOFA, which is, of course, very important as a sign to use, especially in the emergency department. But you can also look at some biological signs, look at the occurrence of thrombocytopenia, that indeed is a very important sign of the endothelial activation. Also, we can look at urine output, but we need to be careful with urine output because it takes at least 1 hour to be stratified as a low urine output in our patients.
Thank you. Daniel, would you advise something more?
Well, again, I mean, the clinical signs are very important, especially perhaps looking at capillary fill time, looking, as we mentioned, the mottling, just the skin temperature is also something very important. And so do not forget these clinical signs, not always used in trials, but very useful at the bedside.
Thank you very much, Daniele. We have got the answer from the audience. 90% of the people respond to the question number C, that was correct. Perform blood culture and give antibiotic as soon as possible before sending the patient to the operatory room.
I'm very happy that the vast majority followed indeed the guidelines, because the guidelines suggest or recommend in these conditions that we should give antibiotics as soon as possible after recognition of sepsis. And indeed, this should be given within 1 hour, but basically as soon as possible in these conditions. Well, the evidence, of course, for this is a little bit coming just from observational data. It's very difficult to randomize patients here, but you can see from these observational data that any delay in administration of broad-spectrum antibiotics is associated with some increase in the risk of death in these patients. So my next question for this patient is, what should we do regarding the initial hemorrhagic resuscitation? Should we give 30 milliliters per kilogram of crystalloids? Should we measure CVP before any intervention? Should we perform the passive leg raising test? Should we measure the SCVU2 to indicate volume replacement? Or should we give right away vasopressors?
Thank you very much, Daniel. And again, for the audience, do not forget to click the orange button to submit your answer, sorry. In the while, I have a question for Sharon. Do you have any comments on this?
Well, yes, I'd like to ask Daniel a question about the guidelines that he's discussing. How pertinent are they for the majority of our patients?
So again, guidelines are very good for the majority, but this is treating patient on a statistic basis. This means that most of the patient will be better treated if we follow the guidelines. Nevertheless, we have some specificities of the patient we need to take into account. Just as an example, a patient with cardiac failure, advanced cardiac failure, should not be treated exactly the same as a patient who is totally healthy prior to develop sepsis. So we may deviate, but of course, we need to mention why we deviate, and so it's good to do some measurements to say that, well, I measure this aspect, so I will be more cautious and I may deviate and not do all the things that are recommended in the guidelines.
Thanks, Daniel. One just a bit more quick question. What do you think of the application of the guideline in some low-income countries? Would they missed some important tools to do some important measurements?
Again, the clinical signs are very important, and especially if you look at the recent Andromeda shock trial performed in Latin America, they were using just a capillary fill time to guide the resuscitation, and they were very successful in showing that these simple signs can be a very useful tool to guide the resuscitation strategy. So yes, we can do these simple signs and not always have the more advanced measurements, but the more advanced measurements are really useful in more complicated cases, of course.
So thank you, Daniel. We got all the replies right now, and 75% of the people reply to the question number A. So give 30 milliliter per kilo of crystalloid. That was the right, absolutely answer.
So it's interesting because indeed this is what is also suggested again by the Surviving Sepsis Campaign guidelines. And indeed these are these 30 milliliters per kilogram. But you can see it is a relatively strong recommendation, but with a low quality of evidence. So the question here is, why is it a low quality of evidence? Because again, we do not have really randomized trials. But if we look again, statistically speaking, in large scale database, what we can see is that the best amount of fluids is comprised somewhere between 15 and 45 milliliters per kilogram. So 30 is just in the middle. But I understand totally that in some patients we may give less, in some patients we may give more. So yes, statistically speaking is good, and so it's correct to go in that direction for most patients. So in this patient, we use indeed this initial fluid resuscitation. We also give piperacillin tazobactam, and the patient was operated. They found some leakage, and they tried to solve it. After surgery, the patient is admitted to the ICU under mechanical ventilation with an arterial and central venous line. On ICU admission, we have the following signs. So mean arterial blood pressure 69. We have indeed some tachycardia still. The patient has a SCVU2 of 65, a PVACU2 of 8, a lactate of 3.9, some moderate dose of norepinephrine, passing urine but oliguric, and of course we have also some moderate hypoxemia in this patient. So one of the signs I mentioned is a PVCU2, so the veno-arterial difference in PCU2. So how do we interpret this value here? It's very interesting because it's a sign that we use more and more at the bedside, in addition, of course, to SCVU2, as you can see here, 65, and the lactate levels there. And so here, this is why we introduce this algorithm here. We base our resuscitation on this gradient here. So when we have an increase veno-arterial CO2 difference, then above 6, this means that indeed there is some alteration in perfusion. So we had here 8 millimeter mercury, so we had indeed some signs of impaired perfusion. The question is it due to a decrease in cardiac output or more local factors? So for this, we look at SCVO2. When the SCVO2 is below 70%, this means that we have the total cardiac output which is inadequate. If SCVO2 had been above 70%, it is mostly then the microcirculation which is impaired. Interestingly, we can go one step further, which is looking at the gradient between the ratio between the content, veno-arterial content in CO2 divided by the arteriovenous difference in oxygen. And basically, this reflects the respiratory quotient. And when this respiratory quotient is below 1, this means that even though the flow is impaired, the cells are still normoxic. When the ratio is above 1, then this means that the cells are hypoxic. Because it's not always easy to compute the content, we can also go for the veno-arterial difference in PCO2 divided by the arteriovenous difference in oxygen. And then the cutoff is 1.3. So in our patient here, we had a low SVO2, an increased veno-arterial PCO2 difference, and a ratio which was at 1.8. This means that indeed we had an inadequate cardiac output associated with some signs of tissue hypoxia. So the question is, what do we do next? Because we have indeed this impaired cardiac output. Do we consider further fluid administration or other interventions, given all the measurements we have here? So should we give further fluids? Well, we may consider that we already gave quite a lot of fluids in this patient, and so that's enough. We can also say, yes, I continue to give some volume to this patient because CVP is only 8 mmHg, and I want to target some higher values. Some others may say, oh, I prefer to try to predict the response to fluids and then to go to the next step. Or some other may say, I prefer to administer the butamine because indeed this may be some signs of inadequate cardiac output. Or I may say, I prefer to give vasopressors to increase the blood pressure because the patient was still hypotensive. Well, in this condition, it's probably better to first try to predict the response to fluids. Why? Because indeed, fluids are often a very good alternative to try to increase cardiac output. And indeed, we have here an impaired tissue perfusion, and we think it may perhaps respond to fluid. The question is, what are the potential benefits of fluids? What are the risks associated with fluids, especially considering we have already given quite a significant amount of fluids to this patient? And also, on top of it, what are the risks of the alternative treatments if we want to go to the butamine or to give norepinephrine to this patient? And then we think that, yes, maybe fluids could be the best solution here. Then, if we think fluids may be the best way, then we should, of course, try to predict the response to fluids. And then, when we think, yeah, this patient seems to respond to fluid, then we administer a limited bolus of fluid, but we evaluate the response to fluid. Because it's very important to measure what you do, so that if the patient do not respond, even though you predicted he would respond, then you have to do something else the next time. So indeed, we give fluids, and then we reassess our patient again and again. Why don't we go just for a specific goal or target for the CVP? Because the problem is that it is very difficult to define what is the best CVP. What we just know is that the very low value, yes, most patients respond to fluid. With the very high values, most patients do not respond to fluid, and of course the risk will be even higher in this patient. But in the middle, which is often the case, like in this patient, we are unable to really predict the response to fluids. So this is why the actual guidelines really recommend the use of these dynamic variables like the passive leg raising test or pulse pressure variations to predict the response to fluid whenever applicable. So the next question will be, what monitoring do we implement in this patient? We may just keep on with the arterial central lines. This is an option. Or I would prefer to insert a pulmonary artery catheter. Oh no, I would prefer to go for uncalibrated pulse control. Or maybe I would perform the echocardiography first. Really here, I would like to perform the echocardiography first, because this will help me to better characterize my patient. And so I will go in this algorithm by performing the echocardiography first. Do not just measure the vena cava, because this is just one very simple measurement, but I will look at the function of the left ventricle. I will also look at the dilation or not of the right ventricle to try to assess the value of the right heart function, the value of left heart function, and also I would look at the fluid responsiveness. Maybe not only with the vena cava, but also looking at the stroke volume variations with ventilation, which are very important here. When my patient with all these measurements has a rapid improvement, then I could indeed expect and reevaluate frequently my patient. I suggest often to use a continuous, non-invasive cardiac output measurement in these conditions, because it gives me also alarms and trends, and also have to have something which is nerves-driven, so that the nerves can call me when there is a problem, and not just I have to come to the room to see what is occurring there and to reevaluate my patient. And when I do not do it, nothing occurs to my patient.
Very interesting, Daniel.
But then when there is no improvement on complex cases, then I have to decide whether I would use a PA catheter or a transperimeter dilution. And for this, again, the echo is very important in these conditions, because then we can select between the PA catheter or the transperimeter dilution. And of course, we reevaluate it again and again. So in this patient, we had indeed this transperimeter dilution that basically informs us that cardiac output is on the upper side, but still not very high. We have a high volumes and the high extravascular lung water. But my patient is still hypoperfused. And so what do? Then we go for, again, because we have persisting tissue hypoperfusion, we evaluate whether our patient is still fluid responsive or not. Then if not, we go, or if the price of fluids are too elevated, we go for angiopic stimulation. And if the patient, if the patient is not responding or not deemed to receive angiopic stimulation, we may consider high minilateral pressure. But then if the patient do not respond, we need to go back to initial blood pressure. As a very important aspect at the end, we need, when the patient is stabilized, then we need to think at progressive weaning of vasopressors and also achieving a negative fluid balance.
Daniel, thanks very much for this interesting talk. We have a quick question from the audience. Does PVSO2 have a reliable value in a patient with increased dead space like COPD patients?
Yes, because indeed it is, so what we are looking is a veno-arterial side. So it's really looking at what occurs in circulation, not what is occurring in the lungs. And so there is absolutely no problem with this. It is still reliable in these conditions.
Thank you very much again. It's the time to invite Sharon to speak about hemorrhagic bleeding shock.
Thank you. So my topic is on hemorrhagic shock, but I'm going to be discussing an atypical case, and I'm going, in order to illustrate this, discuss trauma in pregnancy. So the case I present to you is of a 31-year-old woman who is being brought to the hospital by your emergency medical services after a motor vehicle accident. So this is a blunt trauma. And the paramedic tells you from the location she may be pregnant, and the pre-hospital vital signs are demonstrated on the screen. You have a blood pressure of 100/60, a heart rate of 110, and saturation on room air of 96%. And some of you may have filled the pre-webinar questionnaire, and therefore you will know where to treat the patient. The preferred location is actually in a trauma center. In this study, which was performed on a series of more than 3,000 women that were injured in a motor vehicle accident, in fact, the finding was that there was no change in the mortality of the mother or the fetus. However, the pregnancy outcomes were actually improved when the woman was brought to a trauma center rather than an obstetric center, as suggested elsewhere. So who should we screen for pregnancy in motor vehicle accidents? Any woman that arrives to your hospital of childbearing age that has been involved in a car accident should be screened. And you can assess gestational age either by patient history, if the patient you can talk to, or you can palpate the uterine fundus, and this can be done by an expert obstetrician, and it can be palpated above the pubic crest from the second trimester onwards, or you can perform point-of-care ultrasound in order to look at the uterus and see its size. Why is it important to actually understand the gestational age, because over 24 weeks is the age where you might actually salvage the baby if something happens. If you take out a baby that is less than 24 weeks, regardless of what happens to the mother, that baby will probably not be viable. So a little bit about maternal trauma epidemiology. About 1 to 4% of pregnant women are admitted for medical treatment after traumatic injury. And the most common cause of external injuries falls because there is a balance issue during pregnancy. Maternal death rates due to penetrating trauma, suicide, homicide, and motor vehicle accidents are increasing, probably because we now are looking for it, and the new ICD-9 listing actually allows us to ascertain these cases, which wasn't possible in the past. In fact, we know that motor vehicle accidents, domestic and non-domestic violence, and self-inflicted injury are less common, but all of these are associated by more severe injury and a higher rate of maternal death. And motor vehicle accidents account for up to 5% of deaths among women of childbearing age worldwide. So continuing to our case presentation, now you do the Abcde assessment. And looking at A and B, you see that the woman is breathing. She has a respiratory rate of 20 breaths per minute. She has a saturation of 94%. Her heart rate is 120, and her systolic blood pressure is now 90, which is slightly lower than before. The patient is confused, but she's really trying to collaborate. And when you tell her to move her forelimbs, she does it, but she's groaning very much. So she seems to be in pain. And she has a seatbelt mark on her right shoulder and upper abdomen. Now, you also know that she was sitting next to the driver. So what modifications are there to the primary survey? In fact, as you noticed, the saturation may be a little bit low. That is because pregnant women are susceptible to hypoxia, and they have a lower functional residual capacity, and they are therefore more prone to hypoxia and desaturation. Therefore, it is wise to provide supplementary oxygen. In addition, systolic blood pressure is 90, which I mentioned is slightly low. So this could also be because the woman is bleeding, but it could also be due to the fact that the uterine actually does put pressure on the aorta and the vena cava, and that can decrease venous return. That requires that we consider, when we're establishing an intravenous axis, that it be done above the diaphragm, that we consider also manual uterine displacement, and position, perhaps, if it's allowed, the mother in the left lateral decubitus. But again, this is a trauma, and it needs to be considered. Not always is it allowable. So, continuing with our case, you've finished your primary survey, and you're going on to the secondary survey, where you find that there may be an unstable pelvis. Hemoglobin is currently 8 grams%, so you're receiving your lab tests. So so the first question that would come to mind is, what is the sensitivity and specificity of a clinical examination for an unstable pelvis? And this we get from the next slide, where you can see that there is a study that beautifully pooled the data that existed up to that point, and there has been no follow-up on this later on, and showed that the sensitivity is 0.9 and the specificity is 0.9. However, this was not for pregnant patients, and in this case, I have to point out also that it refers to the fact that blunt trauma patients with the Glasgow Coma score greater than 13 and without pelvic pain or tenderness are not likely to have an unstable pelvic fracture. However, your patient is a little bit confused, and she also seems to be in pain when she's moving her limbs, so that's a little bit suggestive. So, what are we supposed to do now? How should we proceed? Should we assess fetal viability by performing one of those tests that I discussed before? Should we give blood and perhaps wait a little bit, do a fast, do an emergency Caesarean delivery, perform a computed tomography, or go to MRI?
Oh, thanks, Sharon. And please click on the orange button again to submit your answer. In the while, a very quick question to you, Sharon. What about if the pregnant woman has also an acute respiratory failure?
So the excellent question, Cesare. I have to say, first of all, the most important point is, like I mentioned before, treatment should not change because of the baby. So for this, I would state, if the patient needs to be intubated, then she needs to be intubated regardless. And then moving on to the various causes that could possibly cause respiratory failure and trauma. If you suspect, for example, fractured ribs and insufficient inspiratory effort, then you should consider the option of CPAP rather than rushing to intubation. And if you suspect, for example, hypoxemia for chest contusion, then possibly you should consider another mode of support that would perhaps increase a little bit more the oxygenation, maybe even a non-invasive form of ventilation, high-flow nasal cannula, or just giving more oxygen.
Thank you very much, Sharon. We got the reply, the percentage of reply. For the A, we have 10%. For the 2, we have 2%. For the C, that is namely the fast, is 73%. We have 14% for E, and we have 1% just for F. But we know that now Sharon is going to reply in a more precise way to all these questions.
So I'm actually going to keep the audience on tenterhooks. Rather than giving the answer immediately, I'm going to go through every one of the options and explain every one of them. So first of all, why not A? So there is a reason, and the reason is that fetal viability, in fact, depends on maternal well-being. So if we start fiddling around with the fetus, we're likely to miss the condition of the mother. Not only that, there is some literature showing that if we see fetal distress, it could actually be an indication of maternal condition rather than fetal condition. So it's very, very important to keep our focus on the mother and not go to fetal assessment at this point. We don't really know what the mother has. And in fact, there's been some literature showing that the fetal distracts a lot of attention away from the mother. For example, here in this study, you can see that women, regardless of the pregnancy age, were assessed by a surgeon only 50% of the time and 100% by an obstetrician, which is really not optimal trauma care. And in another example, again in the same study, shows that FAST was performed for only 24% of the women with a viable pregnancy, with the baby that could survive, but these women underwent a formal ultrasound, an obstetric ultrasound in 99% of the cases. So again, more focus on the baby than on the mother, and this is a mistake. And we need to be aware of this when we are treating these women. So now perhaps B. Should we give blood and wait? And I would claim that in this case, the answer is yes. But I would like to state very clearly that this requires a great deal of observation and caution. So this woman arrived with a hemoglobin of 8. And clearly, as you can see here from the first, second, and third trimester hemoglobin trend, this is already low for this woman. We don't know how much fluid she has received. We don't know the extent of her trauma. And we don't know additional things about the trauma that we should know in order to take care of her. So we should definitely give blood and continue the workup. So it's not actually wait, but continue workup. And having said this, this requires that the woman be in a highly monitored environment, because you really need a high index of suspicion when you see such a decrease in hemoglobin. 40% of pregnancy-related deaths are potentially preventable. And this specific study maybe didn't focus only on motor vehicle accident, but definitely showed that almost all deaths related to hemorrhage were potentially preventable. And this is a very strong point in relation to our case. Now, the American College of Surgeons classifies the percent of blood volume lost ranging from class 1, less than 15%, to more than class 4, severe. These criteria, you would say, do they actually apply to pregnant women? And my answer to that would be probably not. It's very difficult to state exactly where the pregnant woman is in terms of the blood volume loss, but we know that this is not standard, that this does not reflect the standard in pregnancy. And why is that? Because blood volume increases by 30%, plasma volume by 50% and the RBC mass by 20%. So you get a type of physiological anemia, which in essence shows that the mother seems to be anemic when she's actually not. On the other hand, you see an increase in fibrinogen and less fibrinolysis, which shows that the woman has a higher tendency for thrombosis. So she actually can tolerate hemorrhage later, but when she does manifest signs and symptoms of hemorrhage, it's very, very late. And therefore, we need to observe very carefully for bleeding. So for this case, we should start transfusion, and the ratio of blood to blood components should be 1 to 1 to 1, and I refer the audience to the references below for an explanation. We have no proof for anything else for pregnant women. We should try to minimize the amount of fluids given because that could dilute those clotting factors that are well needed, and I'm not going to discuss vasopressors at this point. So secondary survey also suggests an unstable pelvis and hemoglobin is low, why not go for fast? And this is for the majority of the responders, because we see here pelvic fractures, and that would probably be, you could also get a retroperitoneal hematoma. But more importantly, in pregnant women, you can also have placental abruption and uterine rupture. And while these are uncommon, they are associated with other severe injuries, and you see here a beautiful CT examination, an MRI study of this, and fetal neonatal death occurs in quite a large number of these cases. So an option is fetal uterine rupture, and placental abruption could complicate up to 3% overall of maternal traumas. They are more common after blunt trauma. They will increase with an increasing severity of injury, and they may occur even with mild trauma. And the signs and symptoms are listed here. I'm not going to go into those. So ultrasound, in fact, does not suffice. The accuracy of FAST for standard trauma is similar in pregnancy and non-pregnancy. However, the sensitivity of ultrasound testing for placental abruption specifically is low. So for these women, we need something else. We need to move forward for pelvic examination to assess fetal position, vaginal blood, amniotic fluid leakage. We should also be sending a KB test in order to assess whether there is fetal blood in the maternal circulation, because that will give us some indication of fetal-maternal transfusion, and this has to be sent quite early. And I now move to 4. Why not perform an emergency cesarean delivery? Just get that baby out of there and get the problem out of the way. So in fact, why should we? The best area, the best location for the baby is inside the mother. We know that. And in fact, in our specific case, there was also a decrease of the fibrinogen. And a decrease of fibrinogen is a very, very strong hint for the presence of hemorrhage and the likelihood of hemorrhagic complications in pregnant women. Any 100 milligram per deciliter decrease is accompanied by 1.5 times the number of complications of hemorrhage. Now, I'm not going to go into the whole pathobiology of hemorrhagic shock, but mothers, just like any other patient, will go into that coagulopathy, acidosis, hypothermia triad of death. And it is our role to prevent that as best we can and as trauma guidelines teach us. And in the same way, we also know that we shouldn't give too much fluids to these women. Caesarean delivery actually requires an indication. Uterine evacuation may promote return of spontaneous circulation if the mother is already arrested, but this is not our case. And even after the mother has arrested, the fetus may survive up to 30 minutes later. And the mortality of perimortem caesarean delivery in relation to motor vehicle accident is very, very high for the mother and lower for the fetus. And there are questions to be asked here about whether this was the optimal treatment for the mother. So we don't know yet exactly what the mother has. She has not had a workup. Don't get the baby out yet. What about E? Why not perform a computed tomography? Well, it is an option. However, trauma guidelines say that if the patient is relatively hemodynamically stable, go to CT. And we still have no indication that that woman is hemodynamically unstable. We've just begun to give her blood. However, if the patient is hemodynamically unstable, you should probably go to angiography. So again, I would start the blood and continue workup. At some point, we will get to E. Why not F? Well, magnetic resonance imaging in most places it is an option, but it takes too much time. So by the time you get it organized, the woman will probably get worse. So I wouldn't wait for an MRI. So when do we go to CT? In fact, you're allowed to go to CT when the woman is unstable, which I mentioned. And it's important to point out that any diagnostic exposure during CT or during a trauma is unlikely to cause harm to the fetus. You have to have more than 50 millisievert in order to harm the fetus. And if you perform a whole body CT, it's less than 25. If you run a series of a chest X-ray, a trauma, a neck view, it's still going to be less than that damaging 50 millisievert. And don't forget that maternal health takes precedence. So you first and foremost need to treat the mother and forget about the baby in this situation. If you do decide to go to CT because the woman is unstable, you can ameliorate the radiation damage. You can increase the distance between the mother and the diode. You can enlarge the CT slices and still get a very reasonable trauma picture. You can shield if you want to see specific areas that are not the abdomen and pelvis with a lead apron. And don't forget to use a radiation badge to assess the exposure, because that may be crucial for the parents afterwards to make decisions. And again, only use ultrasound or MRI if they're possible. But the most important thing is to have an institutional guideline that will facilitate prompt treatment, and not to start arguing between the surgeon, the radiologist, what we're going to do in a case like this, but decide beforehand what is the best treatment in our facility. So in our case, and this is the real finding for the patient, the computed tomography showed a real pretty convincing pelvic fracture and a retroperitoneal hematoma. Now, one would argue what you need to do now. And in order to make a decision before the patient is taken to the ICU, this is the place to have a multidisciplinary discussion about whether to have an X-fix and a pelvic binder, and there is absolutely no literature on that. So it is really an individual case-by-case discussion. So at this point, the patient is taken to the ICU, but blood pressure remains low, and blood consumption doesn't decrease. And the repeat CT shows that the hematoma has expanded. Should we now wait some more because it might auto-tamponade, go to surgery, or to angiography? So regardless, while people are arguing, the most important thing to know is that the treatment of massive hemorrhage during obstetrics transfusion should absolutely adhere to the regular transfusion protocols. And it's fine to do what you know as you would treat any other patient. Just adhere to what you know. And even if the patient has gone into DIC, you have a variety of guidelines for the diagnosis, for the treatment of DIC, which everybody should be familiar with. And all of these have perhaps mild differences between them, but any option you choose is absolutely legitimate and it is correct. For this specific patient, there was no choice but to go for interventional radiology. And in such a case, if you have, for example, bleeding outside the abdomen and pelvis, then you can use protective measures. But unfortunately for her, we had to do an angio of the abdomen and pelvis. And therefore, in this situation, you can discuss whether you want to extract the baby first and go for packing if you need to go to surgery, or do the angiography first and then extract. What I would do is go for angiography first. And again, this is not literature. This is very much a matter of how you sense the case and what discussion you have with your colleagues. Either way, do not delay the intervention for ongoing bleeding and shock, because the mother needs to be treated like any other trauma patient. Don't wait. And finally, a word about the surgery. So if you do find yourself going to surgery, then the indications should be similar in pregnant and non-pregnant women, in patients. However, since the pregnancy is there, you should always add an obstetrician to the surgical team for cases requiring abdominal or pelvic surgery. You never know how you know how you're going to go in, but you never know how you're going to go out.
Thank you very much, Sharon. I mean, one of the most interesting cases on bleeding I have ever heard. So in the while Andrea is coming back from the backstage, I have just a quick question from the audience. What's about a use of a pelvic binder in a pregnant woman?
So it's interesting. We had this discussion about for a case. There is absolutely no literature on pelvic binding or X-Fix for pregnant women. There are case descriptions, and one would expect that the decision would be based on how much pressure you can put on the pregnant abdomen. So this is a discussion that you would have to have with your orthopedic surgeons and the obstetricians together in order to decide on the optimal care for that patient. It's a very individual decision.
Thank you very much, Sharon. Well, Andrea, how is the audience today?
The audience was very interactive, and I selected just some questions for the presenters, but we had several very good questions. The first question is for Daniel, and the question is about the early use of vasopressor in septic shock in order to reduce the amount of fluid for resuscitation.
It's a very good question, and it's indeed one solution that we need, of course, to balance with the risk of decreasing somewhat, in some cases, tissue perfusion. So in most cases, when the patient is hypotensive, it is a good solution to begin early on vasopressors, and it has been demonstrated that delaying vasopressors is associated in observational trials with an increase in the risk of death of this patient. So what we use at the bedside is usually the diastolic blood pressure, and when it is below 45, we rapidly institute vasopressors without waiting to the effects of fluids in these conditions.
Okay, and the second question is about the type of crystalloid that we should use. What about the chloride content on the solution? What is your opinion on the literature that we have?
So the literature is going in the directions that balanced crystalloids are probably better, again, for a statistical general approach than saline. But we should not forget specific cases. I did not mention the chloride of this patient, but remember that it was an abdominal problem with some vomiting and others, and sometimes these patients are hypochloremic. It will be a mistake to give a non-chloremic solution in this patient. So we need to measure chloride and to adapt our response to the measurements we make. So if the patient is hyperchloremic, no way. If the patient is hypochloremic, then we may consider saline as a first option. But generally speaking, it's probably better to have balanced solutions.
Thank you, Daniel, for the answer. Now move on to the question to Sharon. And the first is about the training. How to be prepared to this kind of event in a pregnant woman. What is your opinion?
So I can understand the concern that led to the question, because in fact it's not a common event, and people are very concerned that they may not encounter such a case. So ideally, some form of simulation is the best solution, and there are actually courses out there that have to do with maternal obstetric emergencies and non-obstetric emergencies that can train you how to prepare for this. And if you do the simulations on a regular basis, like you would do ATLS, then and have the relevant people doing them, then it's very manageable.
Okay, thank you. And the second question is about the incidence and the potential treatment of the trauma-related coagulopathy in pregnancy in light of the physiological alteration of the coagulation cascade and the hemostasis that you mentioned in the pregnancy.
So actually, I find this question quite interesting, because I don't recall seeing a study specifically on this topic, and there is really very little data comparing pregnant to non-pregnant women in terms of trauma coagulopathy. As you saw, in large databases, the numbers that you get for severely ill pregnant women is not very large. So in that case, I would say that we should assume that the incidence is similar, despite the tendency for thrombosis, but we should definitely treat them the same, and not assume that the woman would correct it by herself, but rather that she requires the same amount of support or the same type of support that any coagulopathic patient will require.
Thank you, Sharon. I have just a quick question for Daniel. Is there any role for vasopressin in 2019?
Well, vasopressin is indeed a very good vasopressor. So data overall suggests that norepinephrine is the first agent, and this is true in randomized trials as well as in observational trials. However, vasopressin is a good substitute or at least second agent to consider when the patient is not responding to norepinephrine, and especially if the patient is with some arrhythmias and or with renal dysfunction, when it has been proven to be better in this condition. However, there is some price to pay, and there is also an increase in the risk of digital ischemia. My point of view is that we probably need to ensure that the cardiac output is relatively high or at least normal, because in low cardiac output states, it may be more dangerous than in very high cardiac output states.
Thank you very much, Daniel. And Andrea, let me know, what is your summary? What are your take-home messages?
Okay. The take-home message can be that septic and hemorrhagic shock state are time-dependent conditions that should be treated as early as possible. And following evidence-based treatment algorithms can improve patients' outcomes. And adequate preparation for and understanding of the pathophysiology of shock states enable a methodological approach and a correct sequence of care despite the distractions.
Thank you very much, Andrea. Very important take-home messages. And I have one thing to tell to the audience before close this very interesting webinar is please remember to complete the assessment and evaluation form to get your CME, and all this should be done before December 17. So do not forget this, which is really, really important. And I will also to tell the audience that the next webinar will be on medication safety on the February 18 from 6 o'clock to 7 p.m. So, and last but not least, I want to thank our guests, our scientific support, and overall, I want to thank all the people that were able to carry out this very interesting webinar, also the people who stayed on the backstage to direct this webinar. Thank you very much indeed.